It is a huge honor today to be podcast interviewing Dr. Ntounis, all the way from Fredericksburg, Virginia. Is that a suburb of D.C.?
That is a suburb of D.C. We're about 40 miles south of D.C.
It must be stressful deciding on whether to be a Baltimore Ravens fan or a Washington Redskins fan. You're right in the middle of both of them, aren't you?
That's pretty much the truth. I'm more of a Redskins fan at this point, I feel.
Dr. Ntounis is a dual specialist in the field of prosthodontics and periodontology. He received his DDS degree from the University of Athens Dental School in Athens, Greece in 2005. He went on to complete a prosthodontics residency and a master's degree from the same institution, 2006-2009. Dr. Ntounis then completed his periodontics residency in the University of Alabama at Birmingham and the Birmingham Veterans Affairs Hospital. He achieved board certification with the American Board of Periodontology in 2014. Dr. Ntounis has published over a dozen peer-reviewed papers on the field of implant dentistry and tissue engineering. He has served as an assistant professor at the University of Louisville and maintains a private practice limited to periodontics and implant dentistry and lectures nationally and internationally. His practice, Synergy Periodontics and Dental Implants, is located in Fredericksburg, Virginia, where he practiced with his wife, Dr. Lily Pitman, and he also has an amazing CE course on Dentaltown, from extraction to prosthetic restoration, a comprehensive approach. My gosh, the first thing I'm thinking is it must be very hard to move all the way from beautiful Greece to Alabama. How do you go from Athens to Alabama? Did you get on the wrong plane?
You know, that was it was definitely a cultural shock getting to Birmingham. And the first 6 months, I was still trying to find out, my surroundings. I had a hard time going shopping. I even had a very hard time with my accent to order the right stuff when I was going to the hostel cafeteria to have lunch. With that said, though, over the 3 years that I spent there, I had a fantastic experience. I felt very fortunate to have been accepted in that residency. And last but not least, maybe the most important thing is that's where I met my wife, that we now practice together. She was a first year when I was a second year resident. So fantastic memory from Birmingham. I love my patients in Birmingham, and they offered me a big part of my education and for a big part of who I am right now.
Well, I have had a beer on the beaches of Greece and the beaches of Alabama on the Gulf. They're both beautiful coastlines, aren't they?
That's fantastic. Beautiful coastline.
And Alabama is extremely high tech. I mean, there's a lot of NASA projects and there's a lot of very, very high tech. I want to start off with, podcasters are usually young. I think about 20% of our audience is dental students. And a lot of the dental students, one of their biggest questions is, should I come out of school and be a general dentist or pick one of the 9 specialties? And almost no one picks 2 specialties. What made you pick periodontics and prost?
Well, when I picked pros, I was very, very young, and I loved prosthodontics. I went in. I think I finished dental school. I started dental school when I was 18, because as you know, in Greece we have no college, right? We go straight to a professional school from high school. It's rather competitive. There's only 2 dental schools in the country. I managed to get in after 5 years, so I must have been 23, 24 when I picked prosthodontics, right? So I was very, very, very young, but I knew I had to learn more, and I think that was the driving force behind me picking prosthodontics. Prosthodontics really makes you a good quarterback when we're talking about comprehensive dentistry. I think that was the main reason why I picked prosthodontics. By the end of the second year of prosthodontics, even maybe a little bit earlier, I was working with a guy who was a perio-pro specialist in Athens, one of the best practices in Athens. His name is Dr. Stavros Pelekanos, also one of my great mentors. And he said, Thanos, I think you maybe want to look into that periodontics thing, because you love surgery, you love the aesthetic zone, you love doing the tissue grafts, hardness of tissue grafts, dental implants, and so on. And thankfully, I had the ability, financial ability, and also the driving force to be able to say, well, I'm going to spend another 3 years to go into periodontics. And that's when I started applying for schools in the United States. And thankfully, I was accepted in perio. So back to your question, it's so subjective. It's very hard to tell somebody, well, you need to go out, start making some money, start paying off some of your debt, instead of go to another specialty, spend another 3 years. So it really comes down to what the individual wants and how they see themselves 5, 10 years down the road or 15 years down the road. I loved general dentistry, but at the same time, I thought that I wanted really to kind of go deeper in certain aspects of that, and that was the force behind it. But I understand both ways. Great, there are fantastic general dentists out there, and many of them do better surgery than many specialists I know. So I don't know. It really comes down to what their family values are. It really comes down to how much time they got in their hands, how much money they have. Things that are important. Logistics are important in decisions like that.
Was economics a reason? I mean, very few people leave their mother country. I've read that only 1% of the 7 billion earthlings alive today are living in a country they weren't born in. They say you always leave for only 3 reasons: love, money, or running from the law. Which one of those 3 did you fall under?
That's a good question. None.
None?
No. When I left Greece in 2010, the financial crisis was already starting. But even then, people didn't exactly realize what's coming. I mean, it was coming towards us like a freight train, but people, again, didn't have any idea how things are going to be. So I left at that time just because I wanted to be exposed in a completely different educational environment and go find a place where I can learn periodontics the best way possible. So that was the driving force behind that. In fact, I never planned to stay in the States. My plan was always to go back and work there. Meeting Lily, meeting my wife in residency, that changed a lot of things. Of course, financial crisis hit Greece at that time point, and now retrospectively, you look back to this, you said, "Oh, I basically missed a bullet there." But at the same time, the plan was not to stay in the States.
I just want to ask one political question, then we'll go
Please
back
do.
to dentistry. Ryan and I, we were just lecturing in London, Paris, Glasgow. It seemed like the people were 50-50 on whether the EU would still be in 10 years, 20 years. What is your prediction? Because I'm catching you on a podcast, so they'll be able to Google your prediction 10 years from now on YouTube.
Right.
So what do you think? Do you think it'll stay together, or do you think it'll fall apart?
Interestingly enough, for 2 years, I served as the vice president of the European Dental Students Association. And as a member of the executive committee at that time, I can tell you the energy we had into trying to get together, making good friends, establishing strong relationships from people all over Europe. And I still am a firm believer in the European dream. But what we see right now is that we are failing as a union because we started backwards. We connected monetarily, we connected commercially without establishing the proper frames before we do that. So what you see right now is you have the extremes going up all over Europe, either that's right or left. You have common sense basically dying out. You see a lot of that when it comes to the immigration issue. I don't know about 10 years from now, but what I can tell you is that European Union is going through a huge transition stage, and I just hope that the forces that can keep us apart end up being stronger than the forces that are driving us away. I am not a fan of dismantling or moving away from the European Union. I don't think it's the best benefit of the people.
So I want you to address first a huge can of worms in the dental schools and their thinking. They have, whether or not, in my 33 years or 29 years of dentist, the specialty of periodontics has changed the most. I mean, that didn't happen in pediatric dentistry the biggest change in orthodontics was probably Invisalign, but these kids, they're confused because they hear, well, you don't want to do gum surgery and you don't want to treat this too. Just pull the thing and throw an implant. But then they look at implants. A lot of people are saying that 20% of implants have periimplantitis.
It may be more.
And then a lot of people say, well, why should you retreat this root canal? It'd be easier to pull it. Then the endodontists are showing that they have a 95% retreatment success rate. So let's go into, since you're a periodontist, an implantologist, when do you decide to throw this tooth in the trash can? And when do you decide, to go with titanium? And when do you decide to do good old-fashioned periodontal therapy? And then let that go into periimplantitis.
Sure.
And
Very, very important thing is, number one, recognize the risk factors. People that have periodontal disease, people that you decide to take their teeth out because of hopeless prognosis, and they're losing teeth because of periodontal disease. These are some of your worst candidates when it comes to dental implants. They are going to develop more biologic complications around their implants, periimplantitis, periimplant mucositis, whatever that might be. They end up losing more implants than your average person who doesn't have a history of periodontal disease. So that means that implants are not a panacea for periodontal disease. That's number one. Number two, people in dental schools, as well as practitioners out there, even practitioners that actually have been practicing before dental implants show up, are almost forgetting how to restore teeth. Teeth that are periodontally compromised, teeth after crown lengthening, and so on. So my personal take is, if you have a tooth that can be successfully restored with common sense dentistry, with day-to-day dentistry, without any exotic techniques, you should be putting all your efforts and all your investment into saving that tooth. Save the implant option for the later part of the life of that patient. Because if you're starting right now with a 30-year-old, a 35-year-old, and there is a molar that you could potentially treat endodontically and do a crown lengthening and then put a crown on it, and you want to take that tooth out by placing a dental implant, what's your most long-term study on implants right now? 25 years? Maybe 25 years, right? Well, that person is 30. What's their lifespan? What's their expectancy, life expectancy? We're talking about another 60 years now. So you're almost running out of evidence for the dentistry you're providing. With that said, I feel that if we can save a tooth, let's save the tooth, maintain the implant option for a later time point. And another thing, because periodontists many times are going through an identity crisis. Not all of them, but there's a big part of the periodontal community that is going through an identity crisis. They become implant surgeons. It's important to do good implant surgery as a periodontist because, truth be said, we are the branch of dentistry that we have most of research on implants. We are the branch of dentistry that will continue to innovate when it comes to implant dentistry, come up with new techniques and so on. But at the same time, we are also the people that are going to be here after the implants are gone. And I want to be the specialist that's going to be around after implants are gone. So I don't consider myself an implantologist. Implants are part of my specialty, part of periodontics, as it is as part of dentistry. I have no problem with my general dentist placing dental implants. In fact, my best referrals are people that place dental implants. And I want them to do that, and I want them to do that well. But as I said, it's important for dental schools to focus back on basics, saving teeth, day-to-day dentistry, because implants have pitfalls and they can fail spectacularly.
I want to tell you the mindset of probably 95% of the kids under 30 listening to you right now. When they want to go learn something about peri or implants, they always want to hop on an airplane, fly across the country, drop $3,000 on a weekend. And street smart guys like me are saying, okay, you could take your course on Dental Town for less than the cab fare from the airport to the hotel. You could get a textbook for $100 and read it all. But here's where they just have a roadblock. I say, why don't you go to the periodontist across the street from you and ask him if he learn? And every one of them says this: he doesn't want me to learn what he knows. I'm going to take food out of his mouth. He's not going to be able to feed his children if he's teaching me how to place implants. Is that true or false?
Big mistake.
They all believe it.
One of the things that I learned is there hasn't been a single person asking me or Lily, guys, can I come to your practice? Can I see you doing an all-on-4 surgery? Can I see you doing a tissue graft? And we said no. We would never do something like that. In fact, I would welcome them with open arms to come any day, especially if it's their patient, even better. I want them there. I want them to see the difficulties that I'm facing. I want them to see what's involved. I want them to see the logistics. The other thing, I see general dentists going and buying the latest and greatest of all stuff. They're buying guided softwares, they're buying CBCTs, they're buying a bunch of stuff, and they know very little about actual implant surgery. They end up with a huge overhead that might actually increase because they run into complications, and they're already, on the red, buying all that stuff without being able to provide that service. So if somebody wants to start doing that, they're more than welcome to visit my practice. They can see what's involved, they can see what the logistics and so on, and they can take it from there. But you're bringing up a very good point. How do you feel about your periodontal professors in dental school? Going back, if you had to remember your years in dental school, how do you feel about your perio faculty?
Well, I don't want to say because they know I'll be talking about them. Well, what point are you making?
The point that I'm making is,
actually, I think I can answer that because I just lectured in. I went to UMKC Dental School, class of '87. I just lectured up the street from Kansas City, St. Joe, and I had about 5 of my classmates, and we were going through all of our instructors. And I'm 54, and half of my instructors are dead now. So actually, I can talk about all my instructors because half of them are dead. But anyway, what were you going to say?
The point is, as a specialty, every specialty needs better PR than we already have, especially periodontics. We tend to have more of we're not as open or as welcoming. We need to be a little bit more warm towards our general dentists and especially towards our students.
Okay, but talk through how do you make that phone call? Because I already know what she said. I've had 50 dental students tell me this, and they say, well, I just can't call up my oral surgeon and say, oh, instead of me referring you implants, I want to come watch you so I can learn how to do it so that you won't make any money on me. I mean, how does she even start that conversation with her? She starts the
conversation by saying, I value your education and your training, and I think that you are the person that I should learn some basics when it comes to that particular field. That's how we start the conversation. And the surgeon will say, why don't you come over? I have a couple of cases coming up. Let's make an appointment and you come over. And after those 2 cases, if that general dentist wants to still be involved in that, you take them and you nurture them and you take them step by step. I would not have a problem picking up, if somebody calls me and says, I want to see you doing basic implant surgery. I'm like, more than welcome to come in. Come and see what's involved. Okay, I wouldn't be offended by any means.
But what % of the periodontists think like you in hope, growth, and abundancy versus thinking in fear and scarcity?
I don't know. That's hard to answer. But I know if we are to survive as specialists and if we are to be the leaders that we're supposed to be, we should be acting as a research for our patients and our dental community around us. So part of my vision statement in the practice, because we have a vision statement, if you go to our website, you'll see that, is being resources for the dental community and our patients. So part of that being a resource is exactly that. If you don't think that, if you're just trying to hide small stuff, and if you're feeling that your practice is endangered by showing somebody what's involved in a basic dental procedure, then I feel that the same closed-mindedness will be there in other aspects of life and in other aspects of business. And I don't know of any successful business that has survived with kind of a closed-minded approach.
So your website is periosynergy.com. Where did that name come from, and what would my homies find on that website?
Well, the name synergy is a Greek word. It's a composite word, comes from syn and ergon. It means working together. It means that the sum is better than the individual numbers. So it's me and my wife working together. It's us and our team working together. It's us and our referring dentist working together, and the patient also. So we work synergistically. It means energy. It means working together. It means having a plan. So that's how the word came out. In fact, I have to give kudos to a co-resident of mine, Dr. Mike Nguyen, who's practicing out in California. He's a periodontist, and he was the person who brought up the word synergy when we were talking about all that. In the website, in the Periosynergy website, you will find a lot of our cases, befores and afters. You'll find the services we provide. You will also find a fantastic, I think, newsletter that we put out every 4 months for our patients. It goes out to all our patients, referring dentists electronically, Howard. It has information about us, about our lives, about our practice, about our team, or everything we do with our team. Either that's a volunteer team building experience, either that's whatever that might be. And of course, a lot of good information on our blog about commenting on stuff that are out there, such as the whole flossing situation. that kind of hit us about a month ago about the flows not being in the guidelines for patients.
When you travel around the world, when you go to countries like Tokyo, Paris, London, where most people have a government insurance plan that will only pay you $100 reimbursement for a molar root canal, a lot of people, dentists around the world, do all these government plans, or in America it might be PPO plans,
Sure.
because they build up a big population of patients, and then they do two really big lucrative things. They get into Invisalign and implants. Do you think placing implants is kind of an insulation from PPO, Medicaid, Medicare, government dental insurance that keeps lowering the fees lower and lower and lower because Invisalign and implants aren't covered? And do you think it's a more profitable growth sector of your dental business?
I don't think that profitability has to do with procedure selection. What do I mean by that? As a periodontist, we do treatments that are mostly not covered by the existing dental benefits plans. And you see me being very careful with the verbiage that I'm using. I never say dental insurance. I never mention that to my patients. It's not an insurance. They're part of a dental benefits plan. So as you realize, my practice is a fee-for-service practice. And the reason for that, and how I explain it to our patients, is that I want to be a shareholder toward their oral health. I need to do business with them, not with a company that their eventual plan is monetary. They want to save some money. They want to delay reimbursement to the patient in order to invest in the stock market or in other monetary vehicles. So, for example, if you're doing surgically facilitated orthodontics in order to prevent future periodontal complications when an orthodontist moves the teeth out or a general dentist moves the teeth out, right? How would a dental benefits plan ever cover that? So I don't feel that a specific treatment insulates you from a heavy insurance-driven environment. What insulates you from a heavy insurance-driven environment is the kind of treatment you provide and the kind of practice experience you offer to the patients.
I want to ask you another question. When I asked you about, when do you just give up on a molar and extract it and go with titanium? And you said, if the tooth could be properly restored, if it had crown lengthening. I wanted to freeze frame crown lengthening because on crown lengthening, it seems very obvious that about 10% of the general dentists do about 80% of the crown lengthening. Why do you think, do you agree with that or not? Why is it that probably 4 out of 5 dentists did not do a single crown lengthening or refer to single crown lengthening in the last 2 years? 4 out of 5, easy.
It's just a matter of education, because crown lengthening doesn't mean getting the gums out of the way. Crown lengthening means establishing enough space for a biologic width to form and enough space from the bone to the restorative margin. Okay, so that's crown lengthening. Taking a simple laser, a soft tissue laser, and zapping the gums just to move them away temporarily, that's not crown lengthening. That's basically making space for your restorative material, ignoring future complications that you will have by impinging on the biologic width. So the reason for not getting those referrals, if you're a periodontist or another surgical specialist and you're not getting those referrals, is possibly because you need to spend more time on educating your dentist on the long-term effects of not performing proper crown lengthening and of the long-term effects of basically restoring the teeth without crown lengthening. So just to be specific, say you got a mandibular molar, mandibular first molar, and there is caries. There's caries in the furcation, right? And that tooth needs retreatment because it has an apical lesion. It's already been treated once, okay? And then you need retreatment, and you got the caries, and you got lack of ferrule, and you got all this lack of structure and so on. That is a tooth, Howard, that you can either say, I'm going to heroically retreat the tooth, section it in the middle, premolarize it, and splint the two crowns together. That's a treatment that we did back in the 80s. Or that's a tooth that you might say, well, I'm going to extract that tooth. So that's a molar where I would consider these two options. Most of the population, I would suggest the implant option for a molar like that, because I feel that most of the population is more prone to developing caries. But if you got a hygienist lady who's using Periodontics every night, hasn't had any kind of filling in her life, and can maintain her teeth clean, I would definitely consider sectioning that tooth, retreating it, and placing 2 individual crowns. So
I want to go back to that woman
yeah.
that you're going to premolarize it. There seems to be a big debate on whether or not you go into dental offices and you see like grandma who's coming every 3 months for perio maintenance for 10 years, and the office has never seen grandpa. And then when you do see grandpa, he's just got a mouthful of disease. Do you think, I mean, obviously periodontal disease is multifactorial, but do you think kissing a partner every night with untreated periodontal disease contributes to the other partner's periodontal disease?
Absolutely. Absolutely. Because periodontal disease is a chronic inflammatory condition, but the trigger is bacterial. So by getting exposed to the same kind of periopathogens, you will develop potentially types of gingival disease, types of gum disease because of the same periopathogens. In fact, there has been emerging evidence that shows. I have a dog. Her name is Sophie. She's a black lab mix. She's a rescue. She's 8 years old right now. I love hugging her and I love kissing her. But there's literature that says that there is periodontal pathogen migration from her mouth to my mouth. So if I was somebody who was not up to their oral hygiene and so on, I could potentially have types of periodontal disease because I was exposed to the periodontal pathogens that my dog has.
And I also read a study when they started doing genetic sequencing that Streptococcus mutans, the only place it could have come from is from cats about 15,000 years ago. So many diseases jump from animal to animal, HIV,
absolutely,
from a monkey to a human. But yeah, so I want to go back to this is a common question they have. They're $350,000 in student loans, so they kind of afraid of buying a CBCT. It's $100,000.
Sure.
Here's some of the concern questions. Number one, is buying a CBCT like buying a smartphone? I mean, nobody wants to keep their, no one would want to have the same phone for 20 years. If my original cell phone would have cost $100,000, I'd be on a Motorola flip phone right now without internet. So do you think a CBCT is like an iPhone and in 5 years you won't even want to get that technology? And question number two, if I practice 2 miles up the road from you, how rude would it be if I sent my CBTs, asked you if you would take them so that I don't have to buy the machine?
I'm going to start from number one. Yes, it is like a smartphone. It is like an iPhone, and it does get old the moment you buy it. It's already old news. So does it help you when you work? It helps me in my work. I need it. I need it every day. So my return on investment makes sense, and that's why I bought it. I know in 5 years I wouldn't even go near that machine. In fact, if I have the ability, of course, I'm going to be updating that machine. So you should be prepared for the update on that machine if you're getting into that CBCT situation. Would it be rude if you send me your CBCTs? No, it would not be rude if you send me your CBCTs. But who's responsible for reading your CBCTs? Say if you send me a patient that has an osteomyelitis lesion or a starting type of malignancy. Am I responsible for providing you with a radiology report? What does each state law says about who's responsible for reading that CBCT? I can give you a CD back, and you may say, I missed somebody's cancer because that guy's CBCT wasn't good enough. So in my practice, the way my practice works, I'm rather frugal in accepting referrals just for CBCTs. Everybody has a CBCT nowadays. I mean, most of my general dentists have their own CBCT. They don't need me for that. And you got even little vans that go around that have CBCT machines in there. So it's not rude, but at the same time, it's not something that I'm interested in growing just because I have a CBCT in my area.
I think your new mission would be how to send all 1 million attorneys in America to Greece. Could you figure that out? Just, I mean, come on, they've already got 11 million people. They'd go to 12 million. And they'd have our problems. Here's another huge question they have.
Yes.
She's $350,000 in student loans.
Yeah.
She just bought a practice. The average the average house that sells is 3-bedroom, 2-bath.
Sure.
The average dental practice that sells is around $650,000. She's 28 years old. She's $1 million in debt. And now she's thinking she's got to buy a $100,000 Lanap laser.
Don't do it. Don't do it. start with what you have. You don't need the latest and greatest. You don't need to buy the practice that has the most amazing technology in it. You need to buy the practice that's well established in the community you're going to be serving. You need to buy the practice that the guy that you're going to buy it from is going to be your best ambassador to the patients in the community and the referring dentists and to everybody. Buy that practice. Even though it has the old flooring, even though it has the old carpeting, even though it doesn't have a CBCT, if your practice works, you're going to be able to buy all that within 3 years. Don't buy the Ferrari from the beginning. Buy the Honda, work your way to buying the Ferrari, or make your own Ferrari eventually. So, especially when it comes to money-making new treatments such as a CAD/CAM machine or a Millennium laser, whatever it might be. I don't want to get into that Millennium thing. They are very open to filing lawsuits pretty easily. So I would say just focus on what you got, start with what you have, and work your way towards that situation. I think I've heard you saying the same thing and being of the same opinion. You don't need the latest and greatest to be a good dentist.
It seems like, millionaires learn to say no every day. Billionaires, that's the only word they know is no. And that's a quote from Warren Buffett. He said, billionaires always say no. I mean, last year, and Berkshire Hathaway stock, his opening letter to the shareholders was he apologized for not making a single acquisition because there was no value that he could find. And it seems like every time the dentists get an idea, they go drop $100,000, and they're not sure as hell not buying cash. It's always borrowed money with interest. And I think it caused them to do stress. It caused them to do stress. I want to ask you a personal question, and you don't have to answer. You can just say skip. There's a lot of young kids in dental school listening to you right now, and they're dating the guy sitting next to them. And they see you practicing with your wife. There's two dentists together. Is that is that a good idea to work with your lover and then go home with your lover? I mean, can you really spend 168 hours a week with your lover, or do you think that's high risk, or do you guys, tell me how that works, and you can pass if you want to.
I think it's a very interesting question, and it's something that we work for every day. It comes down to priorities. So you got to prioritize. You got to say, what's priority number one? Priority number one for me is my relationship and my marriage. I want to save my marriage no matter what. If at some point in life we stop sharing the same vision for the practice, that is a reason for me to move on to a different professional environment, not move away from home. So as long as you can prioritize, as long as you can separate personal from professional, it is a fantastic thing to work with your lover, with your spouse, whatever that might be, because you're able to share that load as long as you can always maintain the same respect you had for that person when you started dating them. If you see that through the process of working together, you're losing some of that respect, then that's a reason to stop working with that person and kind of do your own thing. That's why I think it can work either way. We have set very strict house rules on when we stop talking about the practice at home, on a dinner table, whatever that might be, and we try to follow them. But as everything else in life, you just work on it. And if you stop working on your marriage, it's like stop working on your practice, something will fail at that point of time. The other advantage of working with your wife is not only you can share the load, but you can take fantastic vacation when it comes to dental meetings together. So Lily and I have trips planned at this point for the coming year, and we're going to go all kinds of places, and I think that's fantastic. I'm not just taking my wife with me. I'm going to go there with my partner, and we're going to share that dental experience, and then we're going to make it our own trip for us. So priorities, like everything else.
So has she ever hit you in front of the patient?
Not yet.
Here's another question they're always asking. She wants to get into placing implants. There's high-cost systems like Noble Biocare, Straumann, what have you. There's middle-of-the-road value systems, and you can get some of these under $100, $99 knockoffs from Russia, Israel, around the world. Where do you play? And then she's always going to say, does an osteocyte really care if the titanium is made from Nike or Reebok? So answer that question. High, medium, low cost implants.
That is a tough question, Howard. And I've been thinking about that question for a long time. I work and have always worked with high quality, or I want to say high quality, main marketing brands. I'm working with Nobel mainly, Straumann, and some Dentsply. Do I, look down at the guy who's placing different no-name implants? No, I don't. As long as they know their system, and as long as they can control their complications, and as long as they get the support they need. But I'll tell you one thing: whatever implant system you're placing, and however you see that whole issue is, it is important to critically evaluate your system at the long term. So, for example, on my patients, I'm always very, very critical to make sure that I see those bone levels staying where they're supposed to be staying, if I've done the proper surgery, if I've provided the right soft tissue thickness, and so on. If you just want to implant that stays there for 5 years and then it fails, or it becomes an ailing implant, an ailing implant is something that's not necessarily healthy, then that's a different story. But that doesn't serve my patient population. What serves my patient population is an implant that has been proven with evidence and so on. It just happens that those implants tend to be more expensive. Implant dentistry is expensive, and it gets your overhead way up. If I look at my overhead in the practice, if I was spending most of my time doing IV sedation and soft tissue grafting, I would have very small overhead. Once we start doing these big implant cases, all on fours, sinus lifts, whatever that might be, your overhead goes way up. So you just need to make sure that you don't spend as much correcting mistakes of the past or trying to compensate for weaknesses of the system you're using just because you saved at the front end.
When I go into an oral surgeon's office that does not place implants, their overhead is 35, 39%. If they have a huge implant practice, it's 50 to 60% overhead.
Absolutely.
It's amazing.
And that says that if you're getting into implant dentistry, make sure you can control your complications. Because if you get your complications on top of that 65%, then you're not making any money. And that's not a sustainable situation.
So one of my pet peeves is that when I grinds my gears is, it seems like when I go to dental conventions, whenever someone's talking, it's always a course on like full mouth veneers, and then I'll go in the room and say, "Okay, how many of you people have not done one anterior 6, 8, 10 veneer case in this entire year?" And like 85% of the hands go up. And then you go to the implant course, and it's always 16 implants and all this stuff like that. But when you look at the data, 95% of crowns sent to the lab are 1 unit at a time. 95% of implants are placed 1 at a time. And it's almost always for the first molar. So my very specific question is, she's going to place an implant on a first molar. It's a missing first molar. Does she need a surgical guide, or is that overkill? I mean, she's got a tooth in front of it, a tooth behind it. She's got a buccolingual plate. Does she need a surgical guide for that? Should she have a surgical guide for that? What's the better long-term skill set to develop?
Right. I don't think you need to have a surgical guide for something like that. General dentist who's performing endodontic treatment is more than able to place an implant like that properly in a position that makes sense prosthetically. Now, with that said, if you have a molar that's inclining mesially, and if you have a space that's in between a molar and a half, and you're planning to place one implant, then yes, you do need a surgical guide. You need the wax up initially to know how the final procedure would look like, and then you need the surgical guide produced from that wax up in order for you to place that implant prosthetically. So I haven't seen a lot of sites, Howard, that are perfect space for one molar. Most of the sites, it's a missing tooth, it's been missing for some time, the molar has inclined mesially, the other tooth has come down, so issues are being created just to be sure, especially if somebody's starting with implants, have a guide no matter what, just so you understand how the final procedure will be emerging from that implant.
And when implants started, of course, the largest fear was a paresthesia. You'd be placing a lower implant, hit the inferior alveolar nerve. In this great state of Arizona, that'll ding you about $100,000 every single time. But because of that, people have gone to CBCTs. But you also see a trend towards shorter, fatter implants. What do you think about these shorter, fatter implants so you have such a greater margin of error in not hitting anatomical structures?
Especially in the mandible. Mandible is a completely different animal than the maxilla, right? In the mandible, placing an 8 millimeter implant lengthwise is not considered short anymore. When it comes to the diameter, you want to make sure that you're placing an implant that can withstand the occlusal forces in the molar area. So you need somewhat of a larger diameter. You're not going to place a 3.5 implant in a molar position. In fact, there is systematic reviews and evidence that shows that short implants, and at that time when these reviews were written, 8 was considered short. Now 6 is what's considered short. Short implants tend to be more predictable, having less complications than these huge vertical ridge augmentations that we used to do, that had a lot of potential complications. So in a case where you have a 65-year-old with a bunch of comorbidities, diabetes and so on, and smoking, I'm not going to do a vertical block in order to gain that if I can place an 8 millimeter implant. So any day that patient will get an 8 millimeter implant, and I have no problem with that whatsoever. I feel very comfortable with the long-term prognosis of those implants.
Another question, Regina Hertzlinger, medical PhD economist from Harvard University, her theory was the focus factory, that if you do a lot of something, you get really good at it. How many implants do you think a general dentist would have to place each month or per year for them to reach the critical mass? Well, I'll give you an example. Dentists do fillings and crowns every day. They get really good at it. But they might only make a full mouth denture maybe twice a year. And every time they go to make a denture, they're almost thinking, okay, now, what do you think the critical mass is on placing implants before you're just better, faster?
To make it worth your time and investment to get better, to get good at it, you need to be placing above 25 a month. So I think your step should be 25 a month. If
That's
you're placing, if you're placing, I don't know, 5 a month, that's almost not worth the time and your overhead that you're investing in implant dentistry. So that's how I feel. Because imagine the price that you're paying to get the implant kit together, to have your assistant helping you out, to control possible complications. Most of the sites need some kind of site preparation, that's grafting or whatnot. So I don't think it's worth your time if you're doing less than that.
Some people claim that drawing blood and spinning blood is voodoo. Other people think it absolutely works. Carl Misch, a very famous implantologist, said that it's all unnecessary. Others swear by it. Where are you at in drawing blood?
Growth factors. My thesis in Birmingham, and that was published in the International Journal of Oral Maxillofacial Implants in JOMI, was socket conversions, extractions of human teeth on patients, and basically adding to that 2 types of growth factors. One was the human recombinant platelet-derived growth factor, which is artificially made in a lab, and the other one was by drawing blood, creating PRP, platelet-rich plasma. And the histologic evidence, and Howard, I looked at all these sockets of the histology myself, so I can tell you that with great certainty, okay? Those growth factors carry some fantastic benefits to them. They do seem to produce an equal amount of vital bone as almost not grafting the socket, and at the same time they give you the ability to get the primary stability that you need around your implants. With that said, the question is, does every patient need that? And my personal take on that is no. But if you have a patient who tends to have bone metabolic diseases, osteoporosis, or tends to have other issues that may interfere with good healing, then growth factors is an added benefit and should be added in our armamentarium. So I'm not dogmatic saying you don't need them or you need them in every case. It's not like that. They need to be used when the case is right and when the case is proper. And I think there are patients out there that will be significantly benefited by that technology in now and in the future.
Another thing that it gives everyone a migraine is there's so many ways to bone graft. I mean, there's so many different types of bone, so many different bone graft. Is there like an 80-20 bone graft that you use? I mean, do you do most all of your bone grafts with the same material, the same technique, or or you find yourself doing many different types monthly?
I am all over the place, and we're so scattered on the techniques that we use. Depends on the case that my assistants are always in a mode of having to ask everything before the day of surgery, so they know what I'm going to use. Sometimes I may be using blow graft, sometimes I may be using particular graft, sometimes I may be using scrapings from autogenous bone graft, from autogenous bone from the patient. So there's not one recipe, one type of bone graft that will make your life easier, but what makes your life easier and what's consistent every single time is good solid surgical technique, good solid flap management, good solid closure, and these are the things that make the difference. The bone graft is just a very small part of the equation, and that's why it's changing so much. It's a very variable thing.
You know, I should be grinding my own gears against myself. I'm talking about the high-end elite. Now let's switch to, they just came out with the 2015 economic census report. About 13.5% of Americans live below the poverty line. Most of my pedigree from Kansas is poor, wears dentures. So let's switch to the bottom quartile of America. They have dentures. Some general dentists feel like that if they do place a couple mini implants, that periodontists and oral surgeons frown upon that it's really not a real implant. If someone comes in with loose dentures and grandma's complaining, she has a hard time eating and chewing, she's poor, is mini implants a real technique, or do you just say, no, you could do the same with root forms? How do you treat dentures on the poor?
Sure. I would be more inclined to using regular implants and lowering my fees to a point that is almost comparable with placing mini implants, just because there is nothing more heartbreaking, Howard, than having an elderly patient with a huge failing restoration, either that's on mini implants or regular implants. So for these type of patients, I would probably do the best that I can with things that we know work. I don't know. I think there has been a recent guideline on mini implants, and I don't want to say something that I'm not very well familiar with, that they're not considered permanent. They can only serve as temporary implants. So with that said, I probably would not use them. But going back to your question, from a European background, there are Northern European countries and Western European countries that the social system is paying for those type of patients to even get one implant in the mandible, for example, right in the midline, regular implant, just to get that added, retention for their denture. So there are treatments out there that can be done with regular implants, and we don't have to use something that we know does not optimally work. There are always ways to do that.
If your overhead was 2/3, and you did 3 cases, the third one would be a profit. But if that failed and you had to redo it for free, you basically did 3 cases for nothing. So I want to go to the spare tire concept. We've all seen so many elderly patients that needed a 3-unit bridge.
Yeah.
And they placed 2 implants and a 3-unit bridge. And then 20 years later, one of the implants fails. And now you basically lose the implant and crown and the pontic. Do you think that treatment planning, instead of a 3-unit bridge, that for redundancy and for failures, that it should have been 3 implants on 3 teeth, and that you weren't saving any money doing a 3-unit bridge and saving the cost of the pontic implant because you're not thinking 25 years down the road?
I'm always on the over-engineering side of things. So I would over-engineer everything if I could. I mean, and many times when I do these full arch cases, I don't care about placing another 1 or 2 implants additional to that, whether or not my restorative dentist decides to restore them or not, although my advice is to restore them as they would do with the other 4 implants. Yes, on a case-by-case basis, you would find me more on the side of the over-engineering type of situation, and because it doesn't not Howard, paying another $250 or $300 for an implant when you've already collecting how much ever money for a full arch case doesn't make any sense not to put it in. Just put it in. I mean, come on. It's not a big deal.
Yeah,
300 bucks.
that's
You
what I
know?
think. Here's another treatment planning question I have. So you have a patient, he's very happy. Grandpa's happy. He had this implant and crown placed 10 years ago. He can eat cheeseburgers and he can eat anything he wants. And now she's trying to tell him that there's all this bone loss and periimplantitis and this thing's got to come out. And then she's thinking, well, it doesn't bother him. And then she's thinking, well, is there oral systemic links? I mean, is grandpa going to be more likely to have a heart attack or Alzheimer's or from all this periodontal pathogens in his bloodstream? And it's very overwhelming and confusing. How would you tackle that diagnosing and treatment plan? First of all, is that leaking periimplantitis? Is that affecting the overall health? I mean, we see things on the internet that says, they found P. gingivalis and Alzheimer's plaque. They found it in a heart attack. What I like to do is my questions are so bad, I throw 20 of them out, and hopefully 3 of them are good, and you'll answer the best
I think you got some great questions that are applicable to what we do every day and the things that we come across every day. The first thing is you're not supposed to put your head in the sand. So diagnose disease when you see it. We diagnose the disease when we see it. We are the ones that place that implant. So you know the difference between a nailing and a failing implant. A failing implant is an implant that somebody else placed. A nailing implant is a placed. So it's important to identify the disease if it's there. Treat the disease. At least control that inflammation, control the bacterial load, because I'm not familiar with any kind of article right now that says a periimplant lesion has been connected with any kind of systemic situation and so on. But it's not good. We know that it's not good. So I would treat the disease, treat the inflammation. Doesn't mean grandpa has to lose all their implants or you have to remove them and do them all over again and do a bunch of grafting. So I would be more prone into maintaining a healthy situation. What I tell my patients, if I cannot maintain, I tell them, I will maintain something that's healthy, something that doesn't burden your body with inflammatory load, with bad stuff. But I will not supervise neglect. And that's the term I use. I will not supervise. I'm not willing to supervise neglect. And if I keep watching this thing, and if we keep monitoring this thing, it's like me supervising neglect. And I'm not prone to doing that. So, and thankfully I haven't had a lot of pushback when I put things in that order. So it's important to diagnose. Doesn't mean grandma has to lose all their implants.
A lot of the younger millennials are really into cosmetics, fitness, all this stuff. Some of them are thinking about that they want to differentiate themselves by having tooth-colored implants. They see there's a couple of companies creating tooth-colored implants instead of that ugly metal titanium. What would you tell her about that?
Yeah, I would tell them it doesn't matter what color it is. You're not supposed to see it. If you see it, there's something wrong with the tissues around it. There might not be thick enough. There might not be there. If you start seeing your implant, it means that there's something wrong with that implant. So that should not be a concern. It's more, I think that the trend is not so much for aesthetics as it is that metal-free dentistry type of deal, right? Although zirconium oxide belongs, it's in the table. It's a metal. So that for me that doesn't make sense whatsoever. I know
it's okay. The Metal Free Society is like the Anti-Fluoride Society. They're not into facts, so any of those facts won't bother them.
Right. Facts are not for everybody. Facts are not for everybody.
They will never let an inconvenient fact blow their theory.
Right. In any case, we do live in a society where facts are not taken as seriously as they should. And you can see that from our latest political developments that we have in the country. Facts are not as important as firm beliefs from, whatever we were all raised or whatever that might have been. Facts are secondary, unfortunately. So I don't know. I'm not into that. I don't think it's an aesthetic issue. I don't think it's a metal-free issue at all. We're using something that works for now. But as I told you, Howard, I'm looking ahead, and I want my specialty, and I know my specialty will be around after implants.
In a nutshell, when someone does have periimplantitis, is it very much in protocol from periodontal disease around tooth versus implants? I mean, is it basically all the same protocol, or is there different things you do treating periimplantitis around titanium as opposed to a natural tooth?
It's a great question. We've published with Lily on Dental Town that article about implant maintenance and identification of peri-implant diseases. We wrote that to hit a point that basically says that if you have peri-implant disease, Howard, you need to be much more aggressive than periodontal disease. We are fantastic when it comes to treating periodontal disease. We're horrible. We're very mediocre when it comes to treating peri-implant disease. So if you have an established diagnosis of periimplantitis, which basically says inflammatory bone loss around a dental implant, that lesion, that diagnosis has a surgical treatment. A diagnosis of periodontitis doesn't necessarily have a surgical treatment. So peri-implant diseases, we need to be much more aggressive. Implants lack the ability to defend themselves, or peri-implant tissues lack the ability to defend themselves as good as the periodontal tissues. And that's basic fact of life just by looking at the anatomy and the histology between a dental implant and a tooth.
So I'm going to switch gears completely. I get at least one email per day from a dentist around the world saying, is it hard for me to get a license in America? Is it hard for me to come here? In fact, I wish Dental Town really would start a section on that. We have the international forum, you know,
Sure.
but it is the most common question that I get from overseas.
Right.
So what is your experience? Is it hard for a dentist in Greece to come to America in general, or just?
Well, I can tell you in a nutshell what I did and how things worked out for me. First, I did a 3 years, accredited specialty. That was periodontics in the United States. So I did that first. And then I, like everybody else, I took my national boards. I took part 1 and part 2. I did not find them to be specifically or, too difficult. I just found them as regular exams. And then I took a licensure exam. In fact, I took REB. And that's what Virginia was accepting, and it's still accepting. And that was pretty much my route to being able to have a dental license in the United States. With that said, when you do a specialty or a residency, the demand of time is so big that you need to be able to go overtime and have a lot of sleepless nights if you're doing all these things at the same time. And that's a sacrifice one needs to make. At the same time, the other comical thing was when I was an assistant professor in the University of Louisville, and I was in the Department of Oral Rehabilitation, teaching periodontics to our dental students. I was taking the licensure exam with my students. And in fact, they were, and they still are, my best friends. They helped me out a lot, being able to find patients to do that exam. They supported me. I didn't know the system. I didn't even know how to go get instruments from wherever they were getting them. I was just used in supervising and taking care of their periodontal patients. So there's a lot of logistics involved. Like everything else in life, as you know, it's just a matter of a decision and the drive to follow through. So I don't think it's a particularly difficult decision. Every country is different, though. I come from a very European country, believe it or not. I was fortunate to be able to do a big part of my education here in the States.
Yeah, I think Greece has got to be one of the coolest countries on earth. I mean, I don't know how you beat that. Well, it's kind of funny because I live in Phoenix.
Yeah.
So before the commercial air conditioner was available, there was
Right.
almost hardly anyone living here. And
Right.
then they built the commercial, I think the first one was called a swamp cooler.
Right.
And so now the metro has 4 million. So in my hood,
Right.
an old building is 50 years old.
Right.
And then you go to Greece and Italy and you see things that are 2,000 years old, 2,500 years old, 3,000 years old. I mean, it's just a whole different mindset. By the way,
But it's important, sorry to interrupt you, it's important to realize for the Greeks, though, that we're not entitled to anything just because our ancestors were very successful. We have an additional responsibility to humanity for safeguarding those values, not only the ruins, but also the values that come with that. And as soon as we realize that, we are going to be able to rebrand. Greece has a great brand we need to use. It's a great marketing tool, such a great identity. And in fact, there's a joke that says being Greek is fantastic. Being born Greek and die as a Greek is fantastic. The in-between is somewhat of an issue.
I got to tell you something. My two oldest sisters went straight into the Catholic nunnery after high school graduation. Mm-hmm. My oldest sister was a cloistered colony monk. She told me the most interesting Greek story in the world. She claims that the people that invented geometry, the Pythagoreans, that was like a monastic religious group that thought they were finding clues to the other world, and that everything went into that would have been like prayer, religion. That really geometry was born of religion. Is that what they told you in Greece?
You can definitely say that. You can definitely say that religion was a big part of Greek civilization, and it was the kind of religion, unlike many times Christianity has been, and I'm a Christian, unlike many times Christianity has been, the ancient Greek religion allowed them to always look for more clues, to always keep searching. Many times we went through periods of time with Christianity that people had to stop searching for answers just because the church was more of a political power than a religious, religious source. So Greeks, with their religion, that allowed them to keep on looking for answers, prosper, look into the science even more. And that was a huge benefit. Geometry was part of that. Theater was another part of that. The gods actually were played by actors on stage. If you do that now for many religions, that would be considered,
death.
Pretty much.
Yeah.
Pretty much. So
my last question, you promised me 1 hour and it's an hour and 2 minutes. Can I ask you just one overtime question?
Please.
You know, when you're an old dog like me, you kind of get set in your ways and you become dogmatic and all that stuff. But it's really hard on a 25-year-old if she took the study models and the x-rays to every dentist and periodontist and oral surgeon in her town, every single person would have a different treatment plan.
Definitely.
That's what they all say. I mean, that's what they'll tell you. She said, I showed it to my periodontist, my oral surgeon, my dentist. I took it to my study club. Not two people have agreed on the same opinion. So is dentistry a science, or is it a religion, or is it an art? I mean, we're supposed to be doctors. How could 10 doctors look at the same study models and x-rays and come out with 10 different treatment plans? And what should she do?
She should listen to all these guys, get the best out of what works in her hands, and just do it. If you saw your MRI, I recently had my ACL repair. If you show your MRI to a bunch of different orthopedic surgeons, they will tell you a whole bunch of different approaches, and that's fine because that's what they're better at doing, okay? So if you show a recession case and you discuss it with me and Lily, our approaches might be completely different. It's just what we're more comfortable with, what we know will work in our hands, and that's fine. So dentistry is an imperfect science and a fantastic art, and it is a lot of fun. The moment we stop having fun with dentistry because we get busy, we get stressed, then we're doing something wrong. We need a reboot at that time. So it's a fantastic profession, and look at where we are. I'm a guy from Greece. You grew up in Kansas, and we're having a Skype interview talking about dentistry. And that's awesome. This is the best time to be a dentist or a periodontist or whatever that might be right now where we are. It's awesome. It's fantastic.
Can I ask one more overtime question?
Please.
You opened up the can of worms. You said it. You said recession. That's another huge debate when they see the abfractions.
Sure.
Some people are saying that's occlusion, TMJ, that's occlusal disease, bruxism. Other people are saying, no, that's recession, that's brushing your teeth, that's sawing back and forth with an abrasive Crest Colgate. What are those abfractions caused by?
I don't know. We don't know, but I can tell you a lot of non-cervical carious lesions, the ones you're describing, are a combination of factors, either abrasion or chemical or whatever that might be, and it's always important to try to identify those issues. Most of those loss of tooth structure are followed by or preceded by recession, gingival recession. The important thing to realize is anytime you see gingival recession, there is bone missing also. Okay, so there's attachment loss on that tooth, and it's important to make sure that the pink goes to pink and the white goes to white. You cannot treat gingival recession with glass ionomer or composite resin, and you cannot treat missing enamel with corneally advanced flaps or tissue grafts. So we should be prepared to find and create clear expectations to the patient. This is how much I can cover, because above that, you're not missing gum, you're missing enamel that has been fractured off.
You have an amazing mind. I love your articles in Dental Town. I love your C courses. I just love everything about you. It was just an honor that you want to spend an hour with my homies today. You're amazing, and give my best to Lily, and I hope to see you again.
Thanks, Howard.